goal today is to talk about new things coming out when it comes to how we screen people for colon cancer, why we screen people for colon cancer, why things changed really in the last 5 to 6 years. And I will break the cardinals, like one of the cardinal rules of being a gastroenterologist, and try to make a case for why colonoscopy is actually not the best thing that we can do on a population-based level for colon cancer screening. I know, RVUs be damned. Sorry, everybody. So, but that doesn't mean that colonoscopy is still not great, and I'll show you the data on that. But by the end of it, I think we'll talk. What we're hopefully talking about is how do we create a system where we get more people involved, capture more patients who need to get colonoscopies, and maybe find a way to do a few less normal colonoscopies down the road. So before giving any talk, it's good to know that no one is telling me anything as you just listened. I just advocated to lower my own salary, so this is not good. What we're going to go over, just a quick vocabulary review of things I'll be mentioning, since especially as a gastroenterologist doing this every single day, there's terms we throw out there that are pretty basic, but also we take for granted what they mean. So I want to make sure we're all on the same page. The who, the why, and the when of screening. Does it work? That one's pretty easy, I think we'll talk about. Why is 45 the new 50? What tests can we use? What tests do we practically use? What's coming new? What's going out? And then also just a conversation about what would a perfect program look like in terms of colon cancer screening if we could control all the different variables. So very quickly, when we talk about screening, right, in any disease, we're going to talk about colon cancer screening today. We're talking about looking for something in the absence of symptoms, right? So we're not talking about patients when we talk about all these different options that have weight loss, blood in their stool, things are changing. We're talking about people who are walking around and to their knowledge feel great. We want to try to find diseases in them before they get to the point where they present with symptoms, in the hopes that either we can treat it and hopefully cure it when we're talking about cancer, and special case of colon cancer, actually talk about maybe even preventing it in the long term. Surveillance in the world of colonoscopy and colon cancer has to do with people who have already had an established diagnosis of colon cancer or precancerous lesions called polyps, which is the next term we're going to talk about, right? So the word polyp in the colon or in the GI tract is a growth, and there's tons of different histological types of polyps. But for this talk and for our conversation, when I use the word polyp here, we're talking about the precancerous types of polyps. And those boil down to really two: the traditional standard polyp that we think about, which is an adenoma, and they come in two flavors, tubular versus villus, and then some hybrid between the two, versus the serrated lesions, sessile serrated lesions, traditional serrated lesions, which again are precancerous, follow a different genetic pathway towards becoming precancerous, and therefore have a different pathway moving forward on how quickly they could turn into cancer. Again, when we're using the word polyp down the road, that's what we're talking about. We're not talking about juvenile polyps. We're not talking about hyperplastic polyps. We're not talking about other muscular types of polyps. So we're talking about the precancerous ones. Specifically then, an advanced polyp is a polyp that is of a certain size, usually greater than a centimeter. It contains certain histological features that tell us that this one was really moving on its way towards cancer. They're in the world of serrated polyps. If it's a traditional serrated polyp, for example, these are higher risk lesions, okay? So when we say there's an advanced polyp, we're saying, hey, this was not just a benign little 3 mm tubular adenoma that maybe would have never turned into colon cancer, even if you never got a colonoscopy. These are ones that we feel pretty confident if they weren't already harboring a little bit of cancer somewhere in there to begin with, they probably would have been turning to cancer in the future. And those patients who have these bigger polyps or more significant polyps, their lifetime risk of colon cancer is different than the patient who had one small tubular adenoma that was 2 mm in size. So we put them in a different category. And that category is also not only important for the patient, but their family history changes. So these advanced polyp patients who have a big polyp, they get their colonoscopy, it's removed, all is good, colonoscopy did its job. That patient's family should know that that finding almost acts like a diagnosis of colon cancer for them in terms of when they start their treatment, their screening and things like that. So then finally, when we're talking about cancers, the word cancer is a humongous umbrella term. There's so many different histological types of cancers that can appear throughout the body, the GI tract included. But for the sake of this talk, most of the time we are going to be referring to adenocarcinoma and how tubular adenomas, villus adenomas, sessile serrated adenomas turn into adenocarcinoma down the road. All right, so just some quick pictures of what we're looking for when we do colonoscopy. The pictures A through G are more of these subtle serrated lesions versus I included down there in the blank panel towards the bottom right here, traditional mushroom-looking type tubular adenoma, villus adenoma. So these guys follow that sessile serrated pathway. And what should come off the screen here is that they're not all really easy to see. This is not me picking bad pictures and being a bad presenter. Like when we are doing colonoscopy, they are subtle. They look like mucus sticking sometimes to the side of the colon wall. They're flat. They're not jumping out at you like this guy down here in the bottom right. And therefore, they're a lot easier to miss, right? You can imagine doing a procedure, you're cleaning off stool, washing with water, putting air in there, and you could blow by some of these very subtle things and just think that was normal colon mucosa, normal fold. For a long time, when people would develop interval cancers between their colonoscopies, you know, you're 50 years old a decade ago, and you came in and you got your colonoscopy and they said, no polyps, come back in 10 years. And at age 57, 58, they have either symptoms or they're like, you know, they had blood in the stool, they get their colonoscopy and there's a cancer there. And sometimes that is just bad luck of the draw, bad timing. But sometimes, especially the shorter the interval is between your negative colonoscopy and when you get colon cancer, we wonder if there was something like this, especially these flat lesions that maybe we didn't see the first time. You know, the biggest risk of a colonoscopy, if we're not going to get into all the risks and side effects necessarily during the talk, but we don't, you know, our fellows and I myself don't necessarily talk about enough that the biggest risk of getting a colonoscopy done is not some tragic, terrifying perforation or ending up in the ICU because you aspirated. Those are thankfully really, really rare, but up to 10% of the time, we're going to miss a polyp when we do a colonoscopy. And thankfully, most of the times, the little polyps we're missing are tiny and inconsequential, but sometimes, especially if it's one of these flat ones, it could be bigger than you thought when you didn't see it. And these sessile serrated polyps follow a different genetic pathway, like I mentioned before, in turning into cancer. So their timeline into turning into cancer is a little bit faster than those tubular adenomas, villus adenomas. So it's a bigger deal when we don't see them. But thankfully, in our training now, as our fellows are going through training, we're much more aware of these lesions and we're better at picking them up. The cameras are getting better, and other things we'll talk about that are helping us find them. So why do we screen colonoscopy? Colon cancer is still one of the leading contributors to cancer-related deaths in the United States in both men and women, seen here in line 2. Lung still takes the lead, and then obviously breast in women jumps over, but it's still a big deal regardless of whether you're a man or a woman. So we want to try to find those cancers early where surgery can be curative. Even if surgery is not curative, give yourself a better chance with advancements in things like chemotherapy after surgery to eventually reach a cured state, or ideally find polyps, take out polyps and prevent cancer altogether, which ultimately, hopefully, I'll show you, will drive down this number further and has already driven this number down. So that's what this graph is looking at here. So why do we screen in general? You can see that up here, I just put a little note there that about 1 in 23 men, 1 in 25 women will have some form of colon cancer in their lifetime. So it's pretty common. You see here on the graph, the incidence in general has been going down since somewhere around the 70s, 80s as the peak. And then overall, the mortality has been going down as well. Part of the reason why the overall incidence is still pretty high, even though it's trending downwards, is population is growing, right? So this is a common illness. More and more people are reaching ages and getting to the point where colon cancer becomes more common. So we're still seeing a fair number of cases, even though the trend is down. But in general, also the mortality is going down. And so I think anybody in the audience or online who's listening would look at this and say, well, this better not be the slide he's showing us to prove that colonoscopy and colon cancer screening works, because I wasn't there in 1970, but I don't think we were doing a great job, a perfect job of screening back then. And even in the 80s and 90s and 2000s, like we still have a long way to go, as I'll show you. So there are other things that impact this downward curve. Screening has definitely been one of them. The increased use and availability of things like NSAIDs over the counter, not for chemo prevention, which there is data that this NSAIDs do decrease the likelihood of developing polyps and colon cancer, but just the more liberal use of these has probably, as a society, impacted that. In general, less smoking has probably contributed, and as well as other societal shifts. But those things probably contribute as much as screening, but screening definitely has a role here and it's definitely helped. So why? So what have we done? What have we shown in the literature as why we should screen? So there's at least 8 trials that have proven some mode of colon cancer screening improves mortality. Okay. And I won't go through every single one, but colonoscopy most recently had a trial that showed improved mortality. And then historically, things like occult blood test that we used to grab from the ER and do with a little smear and the little dropper. We used to give those to patients to do 3 kits at home on their own. That had 3 trials that showed mortality benefit. Flexible sigmoidoscopy, which at sometimes wasn't very flexible at all, actually, had 4 trials associated with an improvement in mortality. And then colonoscopy recently in the last 3 or 4 years had a trial that confirmed what we thought, which is it does improve mortality. So because of its prevalence in our society, how common it is, 1 in 25 women, 1 in 23 men, and the fact that we have a number of different tests ranging from safe and invasive to non-invasive at various different costs and things like we'll talk about. And it's a leading cause of death, cancer-related deaths, right? It makes sense that we should target this as a way to improve health in our community, right? It's going to affect a lot of people, yes, in certain groups and to certain different degrees, but it's something that if we try to make a program that works that works across the population, we should see a societal benefit of people having less colon cancer and hopefully living longer. So the USPSTF, the United States Preventative Health Task Force, agrees with me. And they said, you know what, screening for colon cancer makes sense. And initially their first number was 50 to 75, a level A recommendation. And that stood until about 2021. And then they finally said, you know what, with this trend that we'll look at of people getting cancer a little bit younger, what's going on there, they finally said, you know what, let's start at 45. And so the reason they made that decision, I'll show you in the next 2 slides some of the data that made that decision possible, that / supported that decision. But the other thing I just want to talk about briefly is that we talk about when to start, but actually the recommendations come as a bracket of ages, right? It used to be 50 to 75. Now it's 45 to 75. They give us a recommendation from 75 to 85 then that says, think about it. We can't tell you, there's not enough data, there's not good data that says every 75-year-old should be getting screened the way that we screen a 45-year-old. But from 75 to 85 in the right clinical picture, if they've had polyps before, if their family history is strong, take into context their overall health, right? Does it make sense that this person would do well with anesthesia if they're doing a colonoscopy, that they would be willing to get surgery if you were to find a lesion that would require operation? It just becomes a little bit more of a discussion. So they can't say do it for everyone. And technically, they have no recommendation for anybody over 85. Though I would argue there are some 85-year-olds, 86-year-olds in better shape than I am, and they would have a hard time hearing me say like, hey, you don't need to do this anymore. So I think, again, from 75 on, it's a conversation, just like it should be with every patient 45 and up, but very much more so a discussion of risk and benefits as opposed to a stern, hey, you should really do this unless you have a really, really good reason not to. So why 45, right? So this data, looking back from 1998 to 2019, showed us that colon, 98 on, at that point, we're doing screening at least as well as we've been doing it recently. There's a movement to screen people. So we see the effects of that after 1998 in 50 to 64-year-olds and 64 and olders. We see decreases in the amount of colon cancer happening, right? Like, that is great. That's a sign that we are doing something right. But when you break it down and looked at the younger people, even though their overall rates were still very low, right? It still seems like age is a risk factor for developing cancer. Younger people is the only place on this slide, right, where the slope of the lines are going in the wrong direction. So that data, coupled with this simulation or estimation that they did from models based on what they were seeing, the trends in society, made the argument for not why this was happening, but at the very least, we have to acknowledge it's happening and maybe start looking earlier. So what these scientists did was, based on the increasing incidences and all the data we collect on cases, they said, let's run model estimations on both costs and how much time would be added to patients' life if we started to screen earlier. And so each one of these pairs of bars here on the slide looks at the different tests, okay? So blue bar is we're going to bump it to 45 to 75. Gray bar is we're going to keep it 50 to 75. And you can see, whether you do a colonoscopy, whether you do a FIT test, the blue bar is doing better in terms of adding patient life years. And then you just have to ask yourself, okay, that's great. If we bump it down to 45, we're going to add years to people's lives. awesome. That's why we're doing this, I think. But at what cost, right? And so what this study showed is that, like, yes, especially in the world of colonoscopy, you'd be looking at a 17% increase in the amount of colonoscopies you'd be expecting to do if you bumped down from 50 to 45. And so gastroenterologists, very happy to hear that. And so our societies, AGA, ACG, when this recommendation started to float around, came out and said, like, about time, let's do it. 45 is the new 50. But that wasn't across the board. Like the cancer societies said, that's good to hear, but we don't necessarily know that the data says we have to jump down to 45, right? So there was a little bit of back and forth there, not because anyone disagrees that, like, there's this trend going on, but because it's not 100% clear. Like, this was modeled based data, right? This was not an RTC of any kind, though that would be very hard to design. That was proving it. But again, the idea was that we see this trend, let's start to look a little bit earlier. And so that's what we started to do. And I do think now, between the USPSTF and all the GI Society guidelines saying start at 45, most of our patients, if we have family members who are nearing 45 or just in between 45 and 50, since they might have missed the announcement, have been getting their colonoscopies or their colon cancer screening done a little bit earlier. All right. So again, everything we're talking about here, screening wise, so that was the data behind why we were interested in started earlier. And then ultimately that data on the model system is what prompted the USPSTF to say, let's actually start earlier. The idea, again, is we want to find those average risk patients, all right, who would have previously been waiting to 50 to get their colonoscopy, and let them know that maybe they should start at 45. And their options for testing, we're going to go through next, and the data on which tests are available and which tests are coming. We'll go through that in a second. But again, it's really important to know that those are the patients we're talking about. No symptoms, no family history, no significant family history of a colon cancer or a big advanced polyp, no personal history of polyps because they've gotten colonoscopies before, or cancer, obviously. Those patients who have those other features, right? A family history of colon cancer, their own personal history of a polyp or a cancer, they already have different guidelines and recommendations for when they should either be getting their repeat colonoscopy and which tests they should use compared to others. So for example, I listed a couple here. If you had a mom or a dad who had colon cancer when they were 50, you as their offspring should start screening at age 40. And you should not listen to anything I have to say about all the other tests. You should get a colonoscopy done, because your pretest probability based on your family history is your risk for colon cancer is a little bit higher. And so the little bit of, the little bit we lose with the non-invasive tests means a lot more to you than someone who is truly average risk. So just when you walk away from this talk, don't think that even though I'm going to advocate for some of these other tests in other ways, that we're talking about those patients who are in those special populations, right? So family history, known genetic syndromes that increase your risk of cancers, specifically colon cancer. And getting a family history here involves not just talking about your first-degree relatives, parents, siblings, children, if they had any, but also if enough branches on the family tree have things checking off a box, even if they are a little bit further out, second-degree relatives, third-degree relatives, you can start to either paint a picture that that's enough to sort of bump them into the higher risk category, or if the family tree really does have a lot of different colon cancer instances popping up, or maybe colon cancers in the setting of other cancers like endometrial cancers, breast cancers, maybe we should asking the question of, like, is there something genetic in this family that we just haven't identified yet that would change their recommendations altogether? So this talk focuses on not those people, but it's still important that we get all that information, even though they're not going to hear about all the different non-invasive tests for colon cancer screening. They need other stuff in their life, right, for screening, right? So if you have hereditary non-polyposis cancer syndrome, HNPCC, which is previously more commonly referred to as Lynch syndrome, you're not going to talk about all the great benefits in the new versions of stool DNA testing, blood testing for colon cancer, because colonoscopy is the best test, and that's the test you should get. But you should also be getting other surveillance of the GI tract. You should be getting other cancer screenings in general. So they go into a different category. So in screening, average risk here, so average risk patients here that we're talking about, 45, no symptoms, no family history. There are a number of approved tests that either clinically, practically, we don't use very much, so I'm not going to spend a lot of time talking about them, so I'm going to address them here really quickly, or some of them have been pulled off the market. So for example, that first one there, Septin9, is a blood test. And I think that we could all agree, having ordered in this room alone and whoever's online, millions of blood tests. Oh, someone's calling in. They were very excited about Septin-9. So ordering a blood test is really, really easy. So if you could design a blood test that found all colon cancers, never miss, and ideally found every polyp and never missed, that's the slam dunk, I would argue, right? Septin-9 was not that. It was okay as a cancer, as a test that could find cancer and not even very specific to colon cancer. Septin-9 exists in other malignancies. But it was a blood test and it had reasonably decent sensitivity. And so it was approved and rarely used because it's, again, not very good. And it actually was pulled off the market. Virtual colonoscopies, these are radiographic studies where you go get a CT scan, except as opposed to just getting an IV and maybe some contrast and maybe drinking some barium contrast, you get to do a full colonoscopy prep. You get an IV, you get IV contrast, and you get a small catheter inserted rectally to put air into your colon. So that way, when you go into the CT scanner, your bowels are nice and insufflated, the wall's thinned out so that we can see any lumps or bumps on that thinned out wall that would say, hey, go get a colonoscopy. Practically, it involves really all the hardest parts of a colonoscopy in some ways, like the prep, the time. It's costly, both to the system, to the patient, depending, because it's not routinely covered, for example, by Medicare, Medicaid as a screening test. And then when it's positive, if it's positive, you got to go do it all again and do a colonoscopy. So practically, unless you are President Obama, who didn't want to transfer powers when he was during, I think, his first term, he got a virtual colonoscopy for that reason, that it was just logistically easier than making that, at that time, Vice President Biden president for the day. So he did that without sedation. For the rest of us, probably as easy just to get a colonoscopy or do some of these other things. The combinations and flexible sigmoidoscopy alone, right? So for our non-gastroenterologists in the room, a shorter scope, we use a shorter scope. We don't go as far into the colon. The scopes used to be really hard to navigate and really rigid, so you only got maybe into the sigmoid colon. So now with the flexible scopes, even we can get pretty high up. But again, when you do a sigmoidoscopy, you're ideally just seeing the rectum, the sigmoid colon, maybe some of the descending colon. So we're basically saying whatever's happening in the transverse colon and the right colon and the ascending colon, we're not going to see it. I showed you before on other slides, there is benefit to this. So even though you're not seeing a third, half of the colon, this helps people. But with the advancements in colonoscopy technology, the scopes now being as flexible as they are, and the camera's so good, it's as easy to do a colonoscopy as it is a flex sig in a lot of ways. And so just, again, practically, they've fallen out of favor. I'd also remember that sigmoidoscopy can be coupled with stool tests to sort of increase the intervals between negative tests. Again, at this point now, it's really not, if you're going to go that route, you're doing a colonoscopy or you're using the stool test. You kind of go one or the other. Occult blood testing, the very, very first version, where you had to get 3 different samples over 3 different days. You're looking for, a reaction with iron in the stool sample. It's a lot. Fit testing is better, as we'll talk about in a couple of slides. And you can do that with just 1 sample. So again, just practically not really used very much because fit testing is also pretty cheap now. It used to be the cheapest option on there, but with how cost effective fit is, it really doesn't have a role much anymore. And then video capsules. So they make video capsules that can have a long enough battery, a camera that you can see throughout the whole colon. Again, you got to use a bowel prep. You got to take the time. You got to do the test, bring the recorder back to us, and you're not going to get as good pictures as a colonoscopy. And it's actually not part of the recommended testing algorithm from the United States Preventive Health Task Force. So it's available. The technology exists. It's a good alternative after you've talked about a lot of the other things, but just not routinely used. So what does that leave behind, right? So colonoscopy, which is good for screening. It's good for survey. It's the test for surveillance, right? So after you've done your first colon cancer screening and ultimately ended up at a colonoscopy, either because you had a colonoscopy or you had a positive non-invasive test, you had a polyp, or you had a cancer, God forbid, we are now following you in surveillance. So colonoscopy can do screening, it can do surveillance. If you have symptoms, right? Now we're outside the world of screening altogether. Colonoscopy is the diagnostic test of choice for lower GI symptoms, especially blood in the stool. Then for screening purposes, our other options practically have been FIT testing, which is a stool test done annually, and then DNA, RNA, protein test done on stool as well. brand name, the most commonly one used, Cologuard. We see lots of commercials for that, but there's other tests coming out and other versions of it that I'll show you here today that can be done a little bit less frequently, every 3 years. And then this new cell-free DNA blood test that was just approved out on the market, and that we'll talk about. So we're going to talk about these 4 different categories next. So starting with the newest one, because I think it's the most interesting and ultimately would be the most exciting if we perfected it, right? So this is a cell-free DNA test. It's take a blood sample. You're looking for different markers in the blood. It is actually pretty good. 83% of the time, it will identify colon cancer in patients who have colon cancer. That's pretty, if you have no symptoms, you're just walking around for a blood test, that's not bad, right? Now, what we would love to see is that number be for advanced polyps or even any polyps, but for colon cancer, it's okay. The specificity for having either really small lesions, non-neoplastic findings, and then when you got a colonoscopy, it was negative, was pretty good too. So when you had a negative test, when we subsequently did the colonoscopy, we didn't find anything a lot of the time. So that's exciting. Where the test really loses steam is, like I said, for those precancerous lesions, advanced lesions, it was only sensitive 13% of the time. And when you factor in the fact that there's about a 10% false positive rate on the blood test already, that really leaves almost no sensitivity to this test when it comes to precancerous lesions. So now we have a test that in the world of cancer diagnosis and might be okay to identify cases of cancer, but colon cancer, especially because it gives us this long runway of growth of precancerous lesions called polyps. What we've been trying to do, right, in our screening systems is prevent as much colon cancer as much as we are trying to identify early cases or medium cases and trying to avoid late cases. Colonoscopy lets you do all of that, right? You can find cases earlier. You can ideally maybe even endoscopically cure the patient if you remove it all. But then also you can remove the precancerous lesion so it never turns into cancer. Using this test alone, I would argue based on this data, we shift our scope here in terms of what we're trying to do to being less about preventing colon cancer and more about identifying colon cancers in as many people as possible, which is still, there's something to be said for that, but it's definitely a shift in the paradigm, whereas a lot of colon cancer screening programs are also trying to be preventative, right? When I take out the 3, 4, 5 millimeter adenomas, I'm hoping that actually has put off this patient who maybe would have developed colon cancer down the road. I've saved them from that. And this blood test doesn't do that, sadly. CMS had a standing policy that if you could produce a blood test that had a sensitivity over 74% and a specificity close to 90, they would cover it. And so this test in its subsequent trials hit those marks, and that's how eventually we ended up with the Shield blood test on the market now. The limitations here again, so it's approved to be done every 3 years. That 3-year mark is partially because of the cost. So it's fun now that I get to say these things, but like I remember when Cologuard was like this and it came out and it was really expensive and not covered by insurance. And so even though there was a good non-invasive test that could add things to our screening modality, patients had to decide whether or not they would do something covered like a FIT test, maybe something invasive they didn't want to do like a colonoscopy because it was covered by their insurance, or pay out of pocket like $800, $900, $1,000 for their Cologuard test because they wanted to try something different that was dropped off at their home. The blood test is equally right now on the market going to be similarly somewhat cost prohibitive to the point where the recommendations are the math in terms of economics of it. Would it make sense to offer it as an annual test? And we'll look at next slide. We'll look at some data that shows you the benefit of the blood test. One of the things the makers of the blood test, not shockingly, argued, and other people who have studied the blood test had said, it would be a better option if we could do it every year. But again, the price point has to come down to make it then a viable screening option if you're going to sort of give it out to the entire population, right? So the pros of this cell-free DNA blood test would be you come for your annual physical. It's really easy to add a blood test there if cost wasn't a matter, right? There's not any prep needed. You're not having to go to a special lab. They might need to collect it in a special bottle. But again, once you're having your blood drawn, that's not that big a deal. It's really good at detecting cancer. So there might be people walking around with cancer that wouldn't have done a stool test and wouldn't have done a colonoscopy and only would have ever shown up when their cancer got really bad, that maybe we can find earlier with this. It's approved for every 3 years. And again, average risk, no family history, no genetic syndromes, no prior colonoscopy that had polyps. These patients shouldn't be doing this test. Cons is that it really doesn't help us find those precancerous lesions. So, we're not preventing cancer anymore. And the cost is going to limit how good it is. So this slide, another model-based study just published last year, looked at trying to make the argument and I think showing the argument that like the best screening test that exists is the one that the patient will do, right? So all the pros and cons we talk about, all these tests that we'll keep going back to, ultimately this black bar, right, is if you did no screening whatsoever and how much colon cancer would exist per 100,000 patients, right? And then every other bar here in the various different colors is a different form of screening, a screening test highlighted over here. So the Shield test that we just talked about is the solid red bar here, almost drops the number in half if you're doing it every 3 years. And again, the authors in this paper talked about the fact that the effect of the Shield test would actually even be greater if it was offered annually. So not even just making any changes to what they're testing for, which could be improved upon as well. If they could do it annually, that number might be better, okay? But again, annually at the cost, now whether or not it's a viable screening option becomes an issue. Some of the other things here we're still going to talk about. So there's other versions of cell-free testing still to come, different companies. So these are the 2 blood tests, and then you shift down into the stool tests, or the next 4 bars, and then colonoscopies all the way down here. And we'll talk about, again, more of the stool tests coming up. But again, the big takeaway from this slide that we're showing is that even though that blood test is not perfect, even that imperfect blood test will help, right? And we just got to find the right way to use it and yield it in our care of our patients. So stool testing options, not quite the oldest because that was occult blood testing, which we said we're not going to talk about. FIT testing, fecal immunohistochemical testing, takes a part of a stool sample, then looks for microscopic evidence of blood. Very easy, very, very good overall. It's cheap. It's been shown that patients will do a FIT test more likely than they are to do a colonoscopy if just offered right out the gate. So there's some patients that you're going to lose from your office if the only thing you offer to them is a colonoscopy. They're not going to want to listen anymore, and they're going to bypass their colon cancer screening. There's multiple different studies that shown that FIT testing decreases colon cancer mortality. So not just incidences, not just it's cost effective, like slopes go down in death, which is what we would love to see with every test. Again, colonoscopy is going to be our gold standard for sensitivity of precancerous lesions. FIT testing does okay. 23% is not good, right? I just told you that 13% was not good, so I can't say 23% is great. And FIT testing also doesn't pick up or really have much of any reportable sensitivity for those sessile serrated lesions, traditional serrated lesions. And those lesions, those flat, hard to find polyps I talked to you about, again, remember genetically, the errors in their genome lead to cancers that tend to grow faster, and then actually have worse outcomes when it comes to being usually on the right side of the colon. So right-sided colon cancers tend to have worse outcomes than left-sided colon cancers when you don't adjust for other things like specific genetics. So that law, not being able to pick up on those lesions, can be a problem. But because it's so cheap and it's relatively easy to do, we can do it annually, right? So even if your first year, your FIT test was negative, even though it should have been positive, so it was a false negative, we only got to wait 365 days or so before we get another shot at it. And if you do that every single year, the test stacks up pretty well. The sensitivity specificity for FIT drops through the floor when patients can't do that regularly, right? So if you get a -1, skip your doctor's appointment for the next 3 years and try to do another FIT test, that test is now disjointed. You're almost sort of restarting colon cancer screening at that point. So that is a pro and a con, is that you got to have a patient who wants to be on top of things and wants to do it annually for that. And so when they then devised and created a stool test that looked for blood and other things, right? They looked at different proteins, DNA, RNA signals that come out of cancers, come out of polyps, and then tested for those. We said, okay, well, this might be the best way that we can find more polyps, which these tests, the stool DNA test, brand name Cologuard, picks up advanced lesions and sessile serrated lesions better than FIT testing. In a perfect world, they would have been able to differentiate the difference between, like, I have hemorrhoid bleeding versus I have polyp bleeding. It can't necessarily do that. That's not a promise they can make, but it does seem to pick up a little bit of what the FIT test was missing. However, the exchange there, so we get some sensitivity for sessile for serrated lesions. However, it comes at the cost of an increased rate of false positives up to about 14%, right? So that's a lot of anxiety and a lot of colonoscopies in patients who maybe didn't actually need anything. It costs more, even though that's getting better and insurances are better about covering it. So that's less of an idea, but to the system, it is a higher cost than a FIT test. And it has not necessarily been studied directly to show that it's absolutely better than a FIT test head-to-head one-to-one. So where this falls into our tool belt, right, is it's another test, has great marketing, especially when it comes to the brand name there, the Cologuard. It is sent to your home. So there's one less barrier that you have to get over. With the FIT test, you have to sort of get the stool kit, take it home, bring it back. In some models, there are other healthcare systems where we could do all of that just the same way that the stool DNA test is done, where it's all do it at home and mail it back in. And it's still non-invasive. So patients are like, I don't have to do a colonoscopy, and they get to do it less frequently, right? So if you have a negative Cologuard test, you might not need to do that. You don't need to do that again by the guidelines for 3 years. And so now they don't have to worry about following up every single year if they want to skip their annual physical. Its specificity and sensitivity do get worse as patients get older. And so again, that kind of creates other issues. We're going to get more false positives, potentially some false negatives in our older population, just to keep in mind. So when they're trying to now perfect this version of a stool test, the new and improved version of a DNA stool-based test, which will be coming out this year, it compared itself to the old version of the stool DNA testing and found that sensitivity, specificity all came the same. But now, in what they're testing for, they could actually drop that false positive rate down to below 10%, closer to actually 9%. So again, 14 to 9, 13 to 9 doesn't sound crazy, but when you're dealing on a population-based level, that's a lot less needless colonoscopy. So that's actually a pretty big jump for this stool test. And where that, again, will fall into things like coverage, costs, and things like that is still to be determined. But it's coming down the road that test, that newer version of the test, might be a little bit better than the old one we've already had out. Then there's also a stool-based test that is a combination of a FIT test plus looking for different RNA markers that, again, has very good sensitivity for cancers, actually seems to do pretty well with picking up advanced precancerous lesions with good specificity, where, again, this is going to be hitting the market and available, and again, cost, whether or not insurances will cover it, that'll sort of play a role. But that's actually very promising data as well, that there's going to be multiple options here, both for these different companies to compete against each other a little bit, and then also just good options that with good data that says non-invasively we can find, again, precancerous lesions as much as we can find colon cancer. So the stool tests are good options. They're non-invasive. Their cost relative to a colonoscopy is cheap, but obviously the FIT test is really cost effective. All these different stool plus tests, stool plus blood plus DNA plus RNA, get a little bit pricier. Obviously, I think the other thing we have to talk about is that the strength of any of these non-invasive tests really connects back to how strong is your healthcare system, right? Because I'll show you in a second here that if you can send out a stool test to everyone, that's great. And everyone does it, that's awesome, unheard of. But then if we don't have the mechanics and the infrastructure in place to follow up on those results, get the necessary follow-up colonoscopies in patients who test positive on these tests, because that's the next step, right? You get a positive stool test, you need a colonoscopy. Then the stool test was for nothing in a lot of ways. Like, we got a positive test and we didn't change the potential negative outcome. So this is at a gut in 2021 data that showed that patients, not shocking, if you got a positive FIT test and you didn't do your colonoscopy, guess what? Your mortality rate up here, orange, is higher than the people who got their colonoscopy. Also, in that same cohort, it kind of showed you that even people who test positive with FIT, only 43% had completed their colonoscopy by 90 days. 51% by half a year, and then only 56% by a year, which, again, whether or not that's all patient driven or that's a system limitation, right? Like, we can't get everybody in. It's hard to get everybody in, is something that when you're creating and talking about these systems, you have to factor that in. It's not just a question of how good is your test if you can't ultimately do the follow-up steps after that. And on that comment with this, 90-day, 180-day, 360-day mention here, the exact timeline to when you should do your colonoscopy after a positive stool test is not by data well determined. everyone agrees sooner is better, but what is soon, we don't really know. I think for patients, anxiety and feelings, right? Like the second they get a positive stool DNA or a FIT test, they would like their colonoscopy the next day. And we would love to be able to offer that to them. But also then understanding that there are some papers that show getting your colonoscopy, day one after your FIT test to within 9 months, for example, the outcomes of all those patients are similar. So it's not like drop everything, drop your whole life, don't do anything ever again until you get your colonoscopy done. But we got to get better than 56% of people who have a positive test, even thinking to do a colonoscopy within a year. Because even though the exact timeline is not well outlined, if I had a potential colon cancer in me for a whole year, I think logically we can all agree the likelihood that maybe that case doesn't go as well as if we had found that cancer 2 months after my positive FIT test is pretty reasonable, right? Even if I don't have an exact study to show you that like 3 months is the cutoff. So the gold standard, as we like to talk about it in GI, colonoscopy is the gold standard when it comes to finding lesions, polyps, or cancer, the potential to remove lesions, to get actual histological diagnoses, potential curative resection, unbeaten in terms of sensitivity, specificity. Where I argue colonoscopy is not the gold standard is in the world of screening tests is that it's labor-intensive, resource-intensive, expensive, and it's limited in parts of our countries, right? So I was trying to make a system for the United States or the world saying everyone get a colonoscopy in some parts of even our own continental 48 states, that is not as easy as it is here in Washington, D.C., where the most bothersome part of getting a colonoscopy is like, I have to do the prep and I might have to wait a couple extra weeks. Like there's other parts of the country where it's like, I need to think about how far I'm willing to drive, getting a hotel, staying over because I don't want to prep and drive 5 hours in the morning, right? And those people are maybe not even the worst case scenarios of these sort of like deserts, healthcare deserts that exist even in our own country. So the other thing to remember is that colonoscopy is the gold standard when we do it well, right? So just putting the camera in someone and saying like, yep, I took a look and taking it out, it could help something really obvious, but the ability to see these tiny little flat lesions as this picture here is showing, it involves the patient doing a good job and getting cleaned out. It involves being a well-trained endoscopist. It involves having all the right tools in terms of the camera, the screen that the camera is projecting to, so you can see these things. And then there's always new tools coming out that are trying to improve on that, right? So we have different devices that have various degrees of evidence that we could add to the end of the endoscopy scope to help us look behind those folds and crevices in the colon. The role of AI is continuing to evolve in this area where can we introduce machine learning to watch the screen with us and do things like highlight little areas with green boxes that stick out to the AI program that maybe draws our eyes to it a little bit better. And so those are all things that try to make colonoscopy as golden as it could be. And when it comes to what you'd want to see, if you can go onto a marketplace and shop for your endoscopist, right? Or have us like come up on stage and hold up our stats and you pick the best of us, what you want to look for is an endoscopist who's finding polyps on screening colonoscopies often. These numbers, the benchmarks set by our societies are probably a little bit low, so that's good. So we should be above them, but the real numbers are probably a little bit higher than this. But at the very least, you want an endoscopist who 1 out of every 4 colonoscopies is finding an adenoma. That suggests they're doing a good job looking for them. Men tend to have them more than women. So if you break it down by gender, if your practice is predominantly men or predominantly women, that number can vary. That's why we split the difference and say 25. And again, keeping in mind that it's conservative, those numbers in general that I usually tell my patients, for men, it's closer to 40% and women more is at 25%. But the idea is that if you're not finding at least 25% of the time, we should be looking into why that's the case. The other newer metric that we introduced is not just finding a polyp, but how often, what is the average number of polyps your endoscopist remember, precancerous polyps, specifically adenomas, is finding per colonoscopy. And that number has been shown, not so all colonoscopies together, but then taking the total number of polyps found divided by total number of screening colonoscopies done, it's shown that the higher that number is. So they're not just finding one and done every 1 out of every 4 colonoscopies. They're finding ideally as many polyps as they can that exist. That number tends to correlate both with patients with doctors who have better adenoma detection rates, and then also decreases the risk of interval cancers between colonoscopies. And then we're trying to get even better about dividing this metric down even further and saying, it's great if you find polyps, but how good are you about finding those really hard to see, hard to look at polyps that I showed you way back on like slide number 4, those sessile serrated polyps, traditional serrated polyps. And what's the right number for that is, again, an evolving number, but you'd like to see that they're finding greater than 3%, greater than 9%. In some studies, they suggested that that was really, really good. But the idea, again, is that an endoscopist should know these numbers about their own practice, because it means they are looking into that, right? They're holding themselves accountable to these things because they want to be as good as possible at their job. How do we make these numbers better? So most other things we talk about is, getting our patients better educated on how to do the cleaning out process, making our knowledge and information more readily accessible to our patients so they can do that more easily. And the better the prep is, the easier my job is. The technology is always advancing. The screens are always advancing, so that the pictures are clear. The role of AI, I mentioned briefly. There is a time element, right? Like we as endoscopists are judged and recommended to spend a certain amount of time looking for polyps during every colonoscopy. And if you do less than that, and your ADR especially is not up to the levels of the guidelines, that would suggest that maybe you should be spending more time looking. Now, there probably is a point of diminishing returns where if you spent 50 minutes doing every single colonoscopy, and how many times the patients wake up afterwards feeling terrible because their stomach is full of gas, versus how many few extra polyps you may have found, that's probably not ideal. But in general, more time, right, to be able to spend that level of detail on patients will produce ideally better results. So now even the guidelines are shifting where it's at least 6 minutes and ideally closer to 10 minutes during a withdrawal of the scope that we're spending time looking for those polyps. And there is something else to be gained, again, at the system-based level, that if we are better about our colonoscopies, we find more polyps, we remove more lesions, then maybe we can do colonoscopies even less frequently than we're doing now. So this was a study, I believe it's out of Europe, but looked at actually like if you had a negative, good, high quality colonoscopy and you were told to come back in 10 years, what would happen if we bumped it out to 15, essentially? And the answer was that the people who, again, average risk, no genetics, no symptoms, they had a great colonoscopy, maybe they could actually even go out further to 10 years. Because again, the technology and the skills are advancing to the point where the yield of a colonoscopy now might be better than it was in 1997, 2001. I'm not sure. They didn't compare it directly to a year, but it's the idea here that if we are really good at it, the other way we can sort of decrease the stress on the healthcare system when it comes to doing colonoscopies is if we don't have to bring back that super healthy, super low risk person 10 years, we can bump them out to 15. We just created a little bit more space in the system to actually get more people into it, right? So colonoscopy strengths, I think, go without saying, is that because it's direct visualization, the tools are better. We will find the most lesions. We can remove them right then and there. It offers the longest time period between. So if you're a patient who wants to know what the risk is and then not have to think about it for a while, colonoscopy offers you that. It's one-stop shopping when it comes to screening, diagnosis, potential full treatment, and then surveillance moving forward. It is costly, time, resources, availability. There's all these different barriers to access like we talked about. And then, not all colonoscopies are created equal, right? So the idea is that we want everyone performing high quality exams. So that way, no matter where you get it done, you get all the benefits that I talked about. So in the last minute here before questions, how can we put all of this together? In the absence of me just creating from the top of my head a perfect 100% sensitive specific blood test, for example, that is also dirt cheap, without that fantasy world existing, right? What can we do? In the United States, we take a more opportunistic approach to screening, which is to say that any access to care that you have, any access point, whether it's your primary care doctor, right? Or especially in females who use their obstetrician gynecologist more frequently, maybe as kind of like their primary care doctor, but it's like any interaction you have with the healthcare system, we use that opportunity to kind of be like, hey, have you done your lung cancer screening, breast cancer screening, colon cancer screening, versus organized screening, which happens in other countries and in parts of our own country where it's like, once you hit a certain age, based on the guidelines, you are enrolled in that screening program, right? So Kaiser in California published their data in 2022 when they said our colon cancer rates, they made a study because they're like, our rates of colon cancer participation is not great. Let's enroll everybody in a FIT program. So when you hit your 50th birthday, we send you a happy birthday card. And when they open it, instead of a check, it was a FIT test, right? Like you think you're getting your birthday present and it's a stool test. And they showed that if they did that, their rates of participation went above the 80% goal, which is what we want to, that was the drive and the push at the time when they designed the study, was to try to get to 80% participation, and that the mortality in their system decreased from colon cancer, right? So that's like an awesome finding. But again, that was a lot of resources going towards one group of people in one state. So trying to design that for an entire country, United States or elsewhere, is really, really difficult to do, but it shows us that it can happen. And there's other countries in the world that could show you that have published similar data of their own organized screening systems. So since our healthcare system is not necessarily designed to do that, how can we optimize our opportunistic screening system that we participate in, whether we know it or not? And I think that's things like this, right? We're talking about it now, each of you from each of your different specialties, or medical students who maybe go out and never practice internal medicine in a primary care aspect ever again. You can see when you see patients in your clinic when they are 45, and if maybe you know whatever they're seeing you for, you're an orthopedic surgeon. I'm not saying you should do their colonoscopy, but just at least raising the question to them and being like, hey, I just turned 45, you're 45. Like, has your doctor been bothering you about a colonoscopy or colon cancer screening, right? We have to use every one of those little interactions, even if it's not the number one on our problem list, to just introduce the idea, because the more you got to seize those small opportunities where we have someone in the healthcare system to try to get them hooked until we can hopefully create a better, more just system, which is a separate point. And so the last thing I'll end with here is you can see that even with this drive, right? So Katie Couric gets her colonoscopy on television years ago because her husband got diagnosed with colon cancer. The goal was to try to get up to 80%. And so even though it's been a mission and a goal of a lot of different organizations, a lot of different people, we're still sort of very slow growth. It's moving in the right direction, 65% all the way up to 69% as of 2020. But again, I think the goal was to hit 80% by 2015. So we're 9 years late and 11% short. So we still have a lot of work to do in order just getting everybody who could be screened. Again, going back to this slide, I think again hits that point that there's 11%, really 31%, but 11% for our goal of people who are just not being screened at all, right? They're the black bar. Right. So if you get them to do anything that I talked about, right, even the imperfect blood test, any versions of the stool test, or yes, come send them to do a screening colonoscopy. Great. Any one of those tests potentially could help at a system level, right? We just got to figure the right way to dispense them. So with that, I would love to take any questions from the chat or here in the lecture hall. Thank you for listening. That's Katie Couric, sitting with Jimmy Kimmel, who just did his colonoscopy live 2 years ago as a refresher of hey, her foundation in honor of her husband. She devotes a lot of time towards colon cancer screening. At one of our main meetings every year, she has a sponsored or a dedicated lecture that one of the leading scientists in colon cancer screening will give a talk on. So it's something that still is really, really important. And I thank you all for listening to me talk about it for about 50 minutes.